Oh, it's all yours.
All right. Hello, everyone. I'm Dr. Sidhu,
And
and
I'm Dr. Kraja.
like we were just chatting, we're both general dentists. Our practice, we're located in Silver Spring, primarily close to a retirement facility, so we have a lot of experience with the median age of our patient base is in the upper 50s. We get to deal with this stuff, so we have a little more exposure to it. Geriatric dentistry isn't really a specialty on its own, like pediatric might be, but it may become one. There are some programs in Canada which are specializing because the aging population certainly has issues that differ, and the management of that is also it's different from just from a general population in the 20s to say even up to your 60s. So we'll discuss some topics that specifically link to how dentistry or your oral health may change as you age. It pertains a lot to how your systemic health might influence your oral health. And then we'll also talk about just how an aging prosthesis, like a lot of as we age, because dentistry is typically done over time, it ages, and the problems that come with it as we get older are also unique. So we'll dive into things of that nature as well. We're always open to questions. Towards the end, we'll discuss a little bit more outside of dentistry about some insurance and sort of how to view those things, and hopefully it's a useful knowledge for everyone involved. So I'll dive in. So the first basic thing that we sort of like to link it back to is oral health affects three major quality of life issues for an aging person. And then quality of life is really what we try and bring everything back to, how oral health affects your nutrition, how you're able to eat, what you're able to eat, the speech, of course, how you're able to speak, which is important. And then there is a social cost to tooth loss that we'll dive into as well. And these are the three major sort of quality of life implications that you're going to have as far as it relates to the relevance of your oral health. So we'll start with how oral and systemic, which meaning generally, how do these two things relate? A lot of times we find patients as they get older, they're not as invested in the taking care of their teeth or their mouth because they may feel that it's not worth it. And I can totally understand where they're coming from. But there is a cost, and that's studied and established with various systemic diseases and how your oral health affects these. So I'll list a few of them, but cardiovascular, this is well studied. So a lot of cardiovascular health comes down to diseases of the blood vessels. And a lot of times when you're thinking of a heart attack or a stroke, it's typically there's some damage to the plumbing, so to speak, in layman's terms, or the blood vessels that supply blood to either the heart or the brain, or and that the inflammation in these blood vessels comes from various sources. But one of the main sources that of course is diet. But one of the other sources that allows the blood vessels to collect these plaques that can cause an occlusion or blockages is inflammation. And one of the common places where a lot of people have inflammation is in their mouth because there's constant bacteria built up. And as the bacteria sort of break down that barrier that is in around our teeth and our gums, they start to enter the bloodstream. And the way that they've been able to confirm this is when they look at plaques from heart attacks and strokes and things like that. There's a bacterial component to these plaques, and that this is essentially making the cardiovascular disease worse, and it's also playing as a risk factor. So if one was to have all things being equal and have a high grade of inflammation in their mouth, their relative risk for cardiovascular disease and bad outcomes goes up. Diabetes is a little different, but it links back to the same thing. Diabetes is one of the things that were the aims of a diabetic person is to maintain their blood sugar. And when you have a mouth that is chronically inflamed, much like if we have some diabetics here listening, you'll notice that if you've ever had an infection, your blood sugar is harder to control. Having gum disease or a higher load of bacteria in your mouth, the body senses that as having a chronic infection. So the way to control blood sugar gets harder. So you're going to see hyperglycemia, chronic hyperglycemia in patients that have untreated gum disease, periodontal disease. And the gum disease itself gets worse. It's sort of a vicious cycle by the diabetes actually making the immunity of the confused, and also causing the natural protective factors that our mouth has to protect against this bacteria. It reduces it. So they really feed off of each other. So diabetes is one of the biggest risk factors for gum disease, and also for diabetic control. Gum disease needs to be controlled, and a lot of times we consult with physicians, endocrinologists for these types of reasons. Then we're going to talk about osteoporosis. Now, it doesn't have a direct link, but of course, our teeth are sitting in our jawbone. So, a lot of times people are limited to thinking about teeth getting cavities, which is a common problem. But a lot of the older population, they have issues with their bone, the bone that the teeth sit in. And that's sort of a slow onset type of issue. The density of the bone, it can affect, of course, how solid the jawbone is and how well the teeth are anchored to be able to be functional for you. The other factor to that also is one of the common drugs that's used to treat osteoporosis are a class of drugs called bisphosphonates. And then the way they work is they cause the turnover of the bone that naturally occurs for everyone. They reduce that. That actually increases chances of something called necrosis, or a non-healing bone, from teeth that have to be removed because of infection. So a lot of times when patients go on these, and these drugs have a long half-life. So once you go on them, they don't really leave your system because they take decades to get out of your system. So before patients go on bisphosphonates, especially if you're getting Zometa or these IV bisphosphonates, they usually will get a clearance from us, and we may treat some teeth, remove some teeth before they go on these drugs. Cancer. Big factor again, not just boils down to a lot of cancers have effect on the immunity. And then a lot of cancer treatment is targeted for high cell turnover because, cancer is uncontrolled cell growth. Saliva is often affected, both with chemotherapy and radiation. And there's increase in mucositis, which is severely affected in from your esophagus going all the way down, because those mucosal cells are high turnover. So these types of things do have an effect on your oral health and your ability to eat. The cancer also has a component of treatment with radiation. If you've had head and neck radiation for, say, a thyroid cancer, any sort of cancer that's in the head and neck region, it's going to have a very particular, and we have some patients who've had that and we see it and it's fascinating. The radiation that exposes the teeth, it creates a different type of disease in the teeth. A lot of times they're really hard to treat. So managing that is important, and it's part of the treatment of cancer that causes those issues. And then the last two here, we'll review medications in detail and how they affect your oral health. But one of the new ones that we've done a separate presentation on just that, one of the forms of, because we're close here to a memory care center, we see patients that are suffering from dementia. One of the most common forms of dementia, of course, there's a vascular dementia, there's also a multimodal dementia that comes from the Alzheimer's is one of the biggest ones. And one of the hallmarks of Alzheimer's pathology and sort of like the way it presents itself is these things called amyloid plaque. So when they study patients, people that deceased, they study the plaques and look at these plaques that are the features of the brain with someone that has Alzheimer's. They find a particular bacteria, and this bacteria is called, just to get technical, it's called Porphyromonas gingivalis. This is the bacteria that causes gum disease. And the reason they think that this is important is because one of the ways that this bacteria has evolved is it breaks down soft tissue. So it can actually transfer from your gums, get into your bloodstream, and it can break down epithelial barriers and make its way back up to the brain. And when they studied this bacteria initially, they thought maybe it was accidental that it was found in there, but then they've consistently found it. And then they found there's the pathogenic factor, that the way that it can break down to go from one tissue to the other, just from like going from your gums into your blood vessels and then breaking these barriers down. That pathogenic factor, they have actually devised a drug for that. And then so now they're actually have done mouse studies and sort of animal-based studies, phase 2 trials, phase 2 and 3 at the FDA, where they've given this to patients that have Alzheimer's, and they've seen that it reduces the progression, reverses it in some cases in animal models. And there's promising studies that are being done in adults as well that have Alzheimer's to reduce the risk factor, this risk factor, the bacterial risk factor. And then it's really interesting because you wouldn't think that those two things would be connected, but they are. And we do a whole presentation just on that. So what is the sort of the physiology of aging? What exactly is happening that's going to impact how you sort of exhibit oral care, or how your oral issues might be different? When we're younger, I mean, we're sort of invincible. We're not facing a lot of these problems, much like we're not facing a lot of general health issues. But to specifically just to create some awareness, manual dexterity is a big issue. Osteoarthritis is a common disease a lot of aging population lives with, and it causes a decrease in the amount of how well you can brush your teeth. I mean, just as basic as that. Oftentimes, a lot of our patients can't floss. So we have some recommendations, so that we'll dive into a little bit later here. And then there's also long periods of convalescence. There's sensory and cognitive decline. If you've ever been to a long-term care facility and seen how well that staff is trained, or how the patient's oral health is in the long-term care facilities, you can pretty much see that, like, there certainly is a big decline in how well that stuff can be managed in long-term care facilities. And to a lesser degree, that's happening in patients that have sort of limited mobility issue, not a ton of cognition loss or manual dexterity, but it's definitely a spectrum. So basically what you're seeing is the decrease in protective factors. Your immune response isn't as good to the bacteria, and you're seeing the increase in pathological factors. Your wear and tear has accumulated, compounded over the years, and you've also starting to lose some of the protective factors that we do with our daily routine. So the disease definitely has it accelerates at this point. Talking about medications here, the most severe side effect for medications, and we mention all of these because all of these, the common side effect is dry mouth. And dry mouth is like one of these things that's you're going to get that from being on antidepressants, which is a lot of the elder population are on these drugs. Antihypertensive, that's just a fancy way of saying blood pressure medications. Any of the blood pressure medications that use to reduce fluid in your body, they're called diuretics. They're also going to reduce the fluid volume of your saliva, because they're essentially reducing the blood volume so that your heart's not under as much stress. Muscle relaxants, decongestants, opioid painkillers, anti-nausea meds, these all work on certain factors that can also, they're also neurological factors, that neurotransmitters that might induce saliva production. So antihistamine might be using it to dry up your sinus, but it's also going to dry up your mouth. Decongestants are working the same way, muscle relaxants, opioid painkillers. This was a huge issue when we just finished school, because we were kind of in this opioid crisis, but severely dry mouth, paper dry. mouth because of opioid use. And again, it's the way that the opioids work, and they block some of the factors that are also used as a communication method in our body to tell itself to produce saliva. Some of the other medications that are anticonvulsants, antipsychotics, certain calcium channel blockers, which are type of blood pressure medications, they have an impact on gum enlargement. So they will actually cause your gums to puff up and get larger. And that creates something that we call pseudo gum disease, which is essentially creates pocketing. So you're not able to actually clean the area in between your teeth and the gums, which is where gum disease is starting. The other sort of side effects are, even a lot of the elderly population is taking antacids and, may not be aware of this, but if you look at the labels to make them more palatable, there's usually added sugar in them. So we have patients that, have it so bad, they might go to sleep with these things in their mouth. And, of course, where, that they start to get decay because you're essentially sleeping with like candy in your mouth. Chemotherapy drugs goes back to some of the stuff we discussed earlier, but generally they affect high turnover cells, and salivary glands, they have high turnover, so they can actually destroy the actual gland itself. And then the other thing that we see is a lot of older patients, they're going to have urinary tract infections. They're going to have things where antibiotics or pneumonia, which was a big issue in the past 2 months, long lasting pneumonia, and may start as viral and then it ends up bacterial. You get put on a broad spectrum antibiotic, you end up with thrush. So basically what's happening in that case is when we're using these antibiotics that have a broad spectrum, they're often killing a lot of the healthy bacteria that's in our mouth. And then the fungus that is present in our mouth, it sort of takes over. That's where you end up with having thrush, which is a common issue that we see here as well. So one of the biggest things, again, we're talking about dry mouth, just the prevalence of that. It's about 22% in the general population, definitely more common. Most of that is in population over 60. Common causes are, again, polypharmacy, meaning they're on a bunch of drugs that have this as a side effect. The other reason would be chemotherapy, where they've either partially or completely destroyed the salivary glands, and so there's just nothing there to produce. There's, of course, patients do get autoimmune diseases, Sjogren's, which is a common one, really debilitating disease. Most patients with this disease will end up losing a lot of their teeth because, again, saliva is just such an amazing protective factor for reducing both gum disease and cavities. And then, of course, there's dry mouth from the consumption of socially acceptable stuff like alcohol and caffeine, because they're dehydrating and they're going to reduce fluid volume. That's going to cause dry mouth as well. Now, with the dry mouth, the type of decay you get is different. It's don't get cavities maybe as much in between the teeth. You get cavities in sort of, we call them root caries. That's just a fancy way of saying there are cavities on the root surfaces of your teeth. They're challenging ones to fix, and we primarily only see this in the elderly population. So as you can see, the root caries it's only going to happen normally when when you're younger, your root is not exposed. But as patients reach that 60 age, you're going to see your teeth get longer. And that's sort of like a chronic result of sort of controlled gum disease, but the gum sort of pulling back away along with the bone and exposing some of the root of the tooth. That root is made out of a different type of tissue. So that exposure is added with the dryness in the mouth causes root caries. And I'm gonna jump into this one here. I want to show you root caries. That's what that looks like. That's an actual tooth. So if you notice that, the teeth are fairly flat. If you notice the edges of the teeth right here on the top. So this person has probably had lost some of their back teeth. They were chewing on the front teeth. They were getting worn down, which causes some gum disease to be accelerated because this is getting a lot of trauma on the front here. And then you get this is root caries. It's a different type of tissue altogether, and this is primarily seen as a result of gum disease paired with some tooth loss that's in a different part of the mouth, and then you end up with this issue. And these are incredibly hard to fix. So this is a really common elderly issue as far as teeth go.
Dr. Sidhu, we have a question here related to dry mouth.
Sure.
Somebody wanted to know, is there a way to enhance production of saliva? Are there certain foods, juices, teas,
Yeah,
things like that
that's
you can do?
absolutely. So we're going to be jumping into that. If you just hold on for in the next couple of slides, we're going to go over several things that can help that. So
Okay.
certainly, but just a little more about xerostomia and how to diagnose that. Sometimes we are diagnosing this for patients because our body has an amazing ability, especially as we get older, to just sort of adjust and not really realize that you have this. So this is a good way to identify this. So what you're looking at here is a it's a typical tongue of a person that has a xerostomia. And the appearance of this tongue, if you were to look at a healthy tongue, you're going to notice it's going to have sort of a pink, a light pink, a whitish appearance on there. This one, if you look, it's sort of a closer to a reddish, strawberry red color. Also has a lot of cracks in it. And so that's all coming from the dryness. The other things that you might notice is you might actually have ulcers, or you may actually be biting your cheek more often, even though nothing has changed with your teeth. And that lack of lubrication, you're actually catching your cheek when you're eating food. A lot of times we see patients that have actually chewed the side of their tongue. And amazingly, patients get used to it, and you're just not aware of it. So with patients like that, we always will give them a lot of lot of information that's coming up on how to manage this. Okay. Um, and then this is here is to answer your question. So there's many products out there. We don't, of course, have any affiliation with any of them, but the fluid intake is important. Of course, saliva is going to be produced by the amount of fluid that's available to make saliva. There are several mouthwashes that are available in both gel form and just liquid. Biotine makes one. Mouth coat is one we have here that we give to patients. Ricinol is another one. These are all different brands. They have a combination of products in there. Yeah.
They have a combination of glycerin and sort of antibacterial agents. It's hard to bring saliva back in a situation where you're taking medications that causes dry mouth, and it's hard to reverse the sort of physiological decrease in saliva that you get. So most of the time, the only sort of true way to to add saliva to the mix is increasing fluid intake. There are one or two medications that do create sort of a overproduction of saliva, one of them being pilocarpine. However, they tend to have a lot of side effects, so they're not typically commonly prescribed. Most of the time, managing sort of dry mouth comes down to managing the symptoms and increasing lubrication, which is with the products like Biotine, Mouth Coat, Ricinol. Typically, they have glycerin in them to sort of smooth out, the effect of that stickiness of the tissues and help move things around in the mouth. Xylitol-containing products. Xylitol is a artificial sweetener that's been found to have antibacterial, especially anti-cavity effects, in that its antibacterial properties tend to affect the bacteria that cause cavities. It's found, in the market, there are lozenges, candies, as well as gum that that you can buy. In general, there's a sort of that Pavlovian effect that happens when you put something in your mouth. It stimulates the production of saliva because it's preparing your mouth to, digest that food. So using things like xylitol lozenges or gums or candies helps stimulate a little bit of that saliva. And in addition to it, adds a small sort of anti-cavity effect to the regimen. With dry mouth comes an associated high chance of cavities, simply because we're unable to buffer the pH in the mouth without saliva. And we're unable to sort of flush bacteria away as easily or move plaque around. It becomes a little bit more dry and harder to brush away. And so when we see patients with dry mouth, we tend to, see over the course of time a gradual increase in the rate at which they're getting cavities. And so when it becomes, when it becomes obvious that we're having a hard time with cavity control, then we add another layer of fluoridated products to manage then the rate of decay that usually follows. And these are things like prescription toothpaste, which you may have had prescribed by your dentist, or the fluoride application that you get at the end of a cleaning appointment. For people who have a much more severe presentation, who may have gone through head and neck radiation or chemotherapy, where the rate of decay increases highly, we do things like trays with fluoride gel that they can wear at night. And there's products that we can use in lieu of restoration, such as silver diamine fluoride, to help reverse some of these areas in the mouth.
I see there's some questions here about if there's a better time to take one of these
dry mouth treatments.
dry mouth treatments during the day. Yeah.
So typically for people who have an issue during the day, we say, throughout the day, go ahead. Another is, in and around sort of food consumption times, so that we're able to produce a little bit of saliva in the mouth naturally, to then be able to sort of lubricate the mouth and push away some of the, the food debris that gets left behind. And another one is at night. A lot of times, naturally, your saliva production decreases. And then if you add that on top of a dry mouth, it becomes helpful to have these products in handy at night.
Yep.
Does xylitol help with dry mouth? Yes, it doesn't necessarily produce saliva, but it doesn't necessarily sort of assist with the mechanism of action, but the chewing of the product in and of itself stimulates salivary production. And then, using something that contains xylitol versus something that contains sugar, of course, there's the antibacterial effect in there.
Yeah, typically anything that has a sort of a tart taste will naturally induce saliva production. So you just pair that with just not adding something like candy, which has sugar in it. That's going to have more of a detrimental effect.
I see another question. Is it bad or good to use toothpick or small toothbrush to use between the teeth? As long as it fits between the teeth where you're not creating trauma, it's actually great. A lot of times with age, as we get more tooth recession, so as we get those root exposures, the sort of apparatus that supports the teeth shrinks away. So you're getting the spaces between the teeth increasing in size, which means when you're flossing, you have a much larger surface area to cover. And so things like the go-betweens, the Proxa brushes that look like little pipe cleaners, the soft picks,
just to clear up,
increase the surface area.
Not the toothpick, like the wooden sharp
Not
ones.
exactly the toothpicks, but some of the rubber products, or some of the sort of little brush products to get between the teeth, especially where you got larger spaces as you go towards the molars, or you have recessions, help increase the surface area of cleaning between the teeth better than floss does.
Water pick, in my opinion, has, if you can use it correctly, will probably have the best ability to clean that as well. But the Proxa brushes, toothpick in the traditional sense, like something that you might see, like the little wooden ones with the sharp tip at the end, I would definitely stay away from that, if that's what we're talking about. They typically, with how sharp they are, you can lacerate the gum, and also they tend to impact food further in between the gum and the tooth areas. Would definitely, anything you're going to use, it should try and disimpact the food from in between the teeth.
Thank you, Tammy. Gum toothpick. Yeah, they make products called go-betweens, or soft picks, that are very good, and a sort of a small enough size to get in between areas very easily.
Yeah, I thought you were talking about the wooden ones. Yeah, definitely don't want that. But one of the things with the silver diamine fluoride is we use it for elderly population It's actually a pediatric product, but it's also being used for, can be used for the pediatric or for a geriatric population as well. It does make the teeth black, which is why it's sort of at the, it's not an ideal situation. It's pretty much used as sort of the last resort because of the aesthetic issues that it has. And then one of the other things about fluoride, because it is present, obviously, what the difference would be between like using a Prevident toothpaste, which is just a higher dose of fluoride, versus a varnish, which you might get at the dentist office, is it's just the way that it's delivered. So the way fluoride works is it works by contact. So the teeth, the tissue that it's made out of is hydroxyapatite, enamel, and all this stuff. So when you introduce fluoride in it, what it's doing is it's creating something called fluorapatite, which is actually more denser than hydroxyapatite. So it's stronger than actual natural enamel. So when you load it, you want to load it in, say, if you have a tendency to get root decay, what we do for our patients is we actually paint it, a lot of it, onto those root surfaces, and it can stabilize that for extended periods of time. Eventually, over the acidity from diet, it will wash away, but the layer of sort of the hydroxyapatite to fluorapatite, it's beneficial. It'll reduce your, even it makes your teeth stronger, essentially. Yeah. Moving. So tooth loss, I mean, how relevant is this stuff, right? So last time I checked, we're about 400 million people in the US. 36 million Americans are completely edentulous. So roughly 10% of the population has no natural teeth. So that means not a single natural teeth present in their mouth. 120 million have at least one missing tooth. So it's a significant issue. It's still prevalent, even though dentistry has come a long way with water fluoridation, but it's certainly still a pretty big public health issue. So a lot of people with that much, we call it, the technical term would be partial or full edentulism. They use dentures. And so, just going to talk a little bit about dentures here. 40 million Americans use them. There's a care for them sometimes is not proper. So we're just going to give you some pointers here. Generally, dentures are made out of a specialized, basically plastic. So you don't want to use abrasive products on it. You shouldn't be using a regular coarse toothbrush to clean a denture. Typically, washing them with some lukewarm water, letting them rinse overnight. And then if you are going to use a product, this Polydent overnight effervescent tablets are good. But generally, it's something that you can also bring into your dentist, and they can put it in an ultrasonic cleaner while you get your teeth cleaned. That's what we do for our patients, and it's a good way to maintain the denture without damaging the plastic that it's made out of.
I wanted to add, there's nowadays everything can be found online, and there are in the market small portable ultrasonic cleaners that people use, marketed towards dental appliances, dentures, retainers, that kind of stuff, that are fairly economical and helpful.
Yeah, and the way they work is basically creating sort of a sound, which is creating a vibration in the denture, so it's going to loosen the debris off. Yeah, I certainly don't. We've had patients use bleach. It will actually turn the dentures white. Definitely don't use that. And we've had patients use, sponges to scrubs and things like that. It damages the denture and actually makes it worse, because then once the denture is scratched, it's going to attract more bacteria and all the sort of the food particles and crud from the mouth. So basic nutrition impact that we talked about is, as far as tooth loss, it's going to be linked, of course, to saliva and food digestion. So one of the things about actually chewing your food and digesting it is, the act of chewing, the way that we're designed, is the act of chewing produces several amylase and these types of enzymes. Also, the lubrication of the saliva, all of this is linked to the actual chewing action, which sends a signal to the body to produce saliva. So when we're edentulous, a lot of times patients will not chew as much, or they will have sort of a semi-liquid diet. The one impact, besides the digestive issues that you're not getting access to all the enzymes that would have been in the saliva, is reflux, your stomach's getting sort of the food that's not as ready for the stomach, so overproduces the acid. You could produce the reflux from that. The other thing is when you're sort of in a position where you're not able to eat, you tend to blend and consume it in liquid form. Now, if you take like a banana or overcooked stuff, you're destroying sort of the fiber in it, or removing the fiber from that food particle. It's going to increase its glycemic index. And glycemic index is basically just another way of saying like how the sugar intake happens. So we want the sugar to be sort of slowly go up. So you get glucose spike from products that we're obviously trying to control for kids, and generally for anyone. It's a sort of high fructose processed sugars, because they cause that sugar spike. I mean, this has an impact in how full you're going to feel and how much of that actually ends up being used for energy, versus it sort of gives you that spike and then you're hungry again. And then, so this all matters. And then the volume of the food matters in terms of, if you're going to blend something down, and how full you feel from that is different. So blood sugar control, satiety, all these things are impacted with how the food is actually consumed. Just a quick, one thing I would say about this is just to think about it as like, if you take a banana and you were to eat that banana, and versus if you were to blend that banana and drink it, even though net sugar consumption would be the same, but the way that sugar may be taken in by the body, it may be faster in the blended form, so may not produce as much satiety. So social impact, of course, talking about the second big thing that's going to happen with loss of tooth, self-esteem. I mean, there's a really good institute that studies quality of life in elderly at the NIH, and they have a nice set of papers that talk about how often people that have teeth that are removable, how often they tend to eat out. There's certainly a link there in the papers that shows that patients, even with good fitting dentures, they don't put themselves in social situations. There is naturally a hesitation to eat in public because your dentures might fall out. And a lot of patients live with chronic oral pain after having dentures, because there is a stigma associated with it that that does create and increases anxiety and depression in seniors, and we see that firsthand here. So these are things that one should be mindful of, that it's going to have an impact on your quality of life. One of the things that
I wanted to ask actually before, there's some sort of a bit of diversion here for other questions, but if you had any other questions pertaining to what we just discussed, feel free to send over.
Yeah, we made this slide.
Does eating hard nuts like damaged tooth or loosen teeth? To a certain extent. So in an aging population, it becomes a little bit of an issue, because there's a certain sort of regular wear and tear. A lot of the teeth, have lived a life and have been restored, one or more times. So there's a lot more areas that are sort of structurally weaker and a little bit more prone to fracturing. So sometimes, though nuts are very healthy, in other ways, it becomes necessary to find, to find other ways to consume them in order to prevent sort of structural failures in the teeth. In and of itself, not really, but when you have dentition that has been, extensively restored, you may have to then alter, the density and the hardness of the foods that you eat.
Mm-hmm. Yep, that's a good question. I mean, I think it's generally a matter of balance. Of course, like if you're chewing ice that has no benefit, that we would always discourage that, because it is going to wear the teeth and there's not a ton of benefit of doing that. Almonds have a benefit of eating, but if you have to look at, that's why each person is more of an individual. Yeah, again, just mirroring what Dr. Kraja said, if your teeth are heavily restored, then you may want to be mindful of how often you're actually eating that. the relative risk is going to be higher than if you eat something softer. Yeah. Diving in a little more about sort of we're general dentists and what that means and what are specialists, because a lot of times we have patients, especially elderly, that don't understand what we do and why do they have to go somewhere else.
Mostly it's because the care becomes a bit of a multi-specialty type of approach.
Yep.
As the issues may become a little bit more complex.
Yeah, so generally what you're going to look at for specialists is they're doing special things. So you may see dentists doing root canals, removing teeth, doing sort of everything. But there's as things get more challenging, even your general health, it's good to involve specialists. So generally speaking, there's going to be the endodontist that does your root canals. There's going to be the oral surgeon that can remove teeth for you. And then you're going to have the oral surgeon and periodontist and possibly even a prosthodontist placing implants and doing some stuff with that as well. And but generally speaking, those are the two big specialists that you may deal with. And the periodontist may also be someone that you see if you have some special surgical issues that you need addressed with your gums. Anything non-surgical can be done in a general practice setting. Of course, pediatric dentists are relevant in this setting, but that's another specialty. So now, when you go to the dentist, what should you expect to get out of that exam? So a preventative dental exam, which should be done at least twice a year. We're evaluating both soft and hard tissues in the mouth. We're checking for oral cancer and a bunch of things that relate to cancer, semi-cancerous, or benign pathologies that we're looking at when we check in the mouth outside of teeth. The other thing that now in the newer age is there's more of a push to diagnose airway disease, which is so OSA stands for obstructive sleep apnea. It seems to be fairly prevalent in the general population. So one of the missions that of the ADA and the general dental exam goals is to screen for obstructive sleep apnea. That can certainly have an effect on your teeth, and it is shown to be a big boost to quality of life if it's diagnosed at the correct manner. It's not diagnosed by a dentist. We can screen for it, but we can give you referrals by asking you some screening questions and actually looking at your airway. Then the second thing here would be you get dental x-rays. And one of the other questions that we get fairly often is, are dental x-rays, like how harmful are they, and how often should you get them, and things of that nature. You should get gum charting 1 to 1.5 years, depending on how much of a gum disease that you're prone to or have had in the past. But that's general guideline is there. For older population, 6 months is the average.
How does a dentist screen for sleep apnea?
So we go off of first a questionnaire. We're going to ask you for general quality of life issues. A lot of patients we may ask, but we stem it from first assessing your airway. So sleep apnea, there's two big kinds, neurological, which we wouldn't be able to tell you much about. That has more to do with your brain chemistry. Obstructive sleep apnea talks about some oral structure that's obstructing the passage of air from your nose into your trachea down to your lungs. A lot of times we can assess that when we look in your mouth by looking at something called a Mallampati classification. So there's 1 to 4 is the score that you give. This is essentially going to tell us where does the tongue sit and what's visible at rest to the back of the throat. So if you're at a Mallampati 4, that means the tongue is mostly covering most of the soft tissue. The soft tissue is covering most of the airway. That's a higher risk for sleep apnea. And you're looking at neck circumference, you're looking at weight, and these things can help us gauge to point you in the direction to say, hey, are you tired when you wake up in the morning? How quickly do you fall asleep? And if those things check off, then we may recommend, hey, what I'm seeing is that you may benefit from going to your primary care. Sometimes we can refer you directly to sleep centers. But typically they will actually let you wear the sleep apnea. The diagnosis happens by wearing something on your head and something on your arm, basically measuring how many times you're apneic or you're lacking air. And the amount of times that that happens will determine if you have actual sleep apnea or not. That's diagnosed by a physician. You get a sleep study report. And then there are some dental things that we can do if you can comply with the golden sort of, the golden thing is still the CPAP machine, but it's not well tolerated. So there are devices dentists can make that can help place your jaw in the right position to open up that airway without having to wear the big sleep apnea device, the CPAP, which is still generally the best. Okay.
Just so you know, we're about 8 minutes to 11.
Okay.
So we can open the for
Yep.
questions.
I'll just quickly go over just two things. Radiation by numbers, because this comes up a lot. This presentation is completely available for anyone. Your regular X-rays these days are not going to have anywhere close to the radiation that's permissible. 1,000 millisieverts is what's deemed acceptable in the US. A typical X-ray will have anywhere from 1 to 8 microsievert. So you can get up to 120 X-rays on the higher end, up to 1,000 X-rays, and still be safe within the range. We never take anywhere close to that. So dental X-rays are safe. And this range depends on the digital systems have even less radiation, because they're able to sort of use less radiation and estimate what the image is. And an update last year was the ADA actually recommends we don't even need to use the lead jackets when we're doing dental X-rays now. They've went back and studied it, and the relative risk is so low that you don't even need the lead jacket for it. We still use it, but just to kind of show you how safe it is, essentially. So it's very safe. And then if there's any questions about this, I'm just going to skip through this. This is more to do with dental insurance. And then these are the resources that we used for the presentation. So we're open to any questions, or we could dive into any of the dental insurance questions.
Okay.
There's one.
Which type of toothpaste to buy? What are the best electric toothbrushes? Are there better manual toothbrushes? The type of toothpaste that you buy may be a conversation between you and your dentist, depending on what your specific needs are. There are formulations that are a little bit better for gum disease and others that are a little bit better for tooth decay. Excuse me. And there's some specialized ones, depending on whether you're high risk for specific things. Because you're right, there's a lot in the market. One thing that we actively discourage patients from buying is the ones that are really sort of heavy on the whitening component. They tend to be a lot more abrasive on the tooth structure, and especially with patients with recession and root exposure, the less of that sort of scraping motion on the root, the better it is. What are some of the best electric toothbrushes to buy? We're big proponents of the Oral-B. We have no sort of skin in the game. But there's numerous studies showing that the round head, sort of oscillating, rotating brushes are a little bit higher in efficiency of cleaning than the vibrating, sort of more rectangular head with the sort of back and forth vibration. So typically we recommend the round-headed brushes to patients, which fall in the category of Oral-B. Are they better than manual toothbrushes? They can both do the same thing. However, all else being equal, for the same amount of time and pressure of brushing, electric brushes consistently in studies go up to 19% more efficiency in plaque removal than a manual brush. So especially when it becomes an issue of manual dexterity, time, sort of cognitive issues or sort of tougher to clean areas, we generally recommend an electric brush if possible.
The other
Are we doomed? My Tesla has issued directions and options. If you two are not escapees from the University Research Department of thank you for that. Who would need a dental cleaning exam every 3 months as opposed to 6 months? Great question. A lot of times this has to be a discussion between you and your dentist, and it has to do with your sort of risk of developing tooth decay or gum disease. Patients that tend to have sort of a genetic component where they tend to build up plaque or tartar that's very tenacious and hard to remove, benefit from a more frequent cleaning schedule, so that they're able to remove that before it becomes chronic enough to cause damage to the surrounding structures. Patients that have a harder time keeping their tissues clean on their own, or, you know, for one reason or another are not able to follow through, or with sort of oral hygiene at home, or the oral hygiene regimen becomes a little bit too complex to sort of manage on a regular basis, would benefit then from sort of making up that difference with more frequent cleanings. And if they have a high cavity risk, it's also important to sort of diagnose things early and therefore see the dentist a bit more frequently, because issues tend to sort of precipitate a little faster in that instance. Brushing 3 times a day too many? Not really. If you can swing it, absolutely, it's great. What are proxa brushes?
Why would someone need a dental cleaning?
Yeah,
3
I
months?
just, yeah,
Okay.
that one.
Okay.
What are proxa brushes? How are they used? What about dental floss? How often to use? So proxa brushes are little skinny brushes. They look like tiny little pipe cleaners, so to speak. They're meant to be interdental. So they're meant to go into the same sort of space where the floss goes. And they cover that little triangle of area where you normally see a gum triangle, or in some people with recession, you may see some spacing. It increases the efficiency of cleaning in that interdental area. So a lot of times we use them in conjunction with the flossing to clean between the teeth. They become more useful, again, when the anatomy gets a little irregular, where spacing is larger. We say in conjunction with the floss because the floss will still pick up some of the debris that the proxa brush will miss. The floss can also be tapered around the circumference a little bit better and can cover that little spot where the teeth touch together, which a brush will not fit through. And how often do you use? Ideally, you want to aim for once a day, and in the evening, it tends to be the best time because naturally your salivary flow diminishes right before bedtime. So you want your teeth to be the cleanest possible right before that period of rest, so bacteria don't have access to as much of the plaque and debris while they have sort of free time and no saliva to remove it.
Some dentists that recommend to put a crown as a preventative measure. Yeah, I mean, so of course it depends on your particular case. Typically, when we're recommending something like a crown, which is essentially a full coverage of the natural tooth with the prosthetic material, it's to protect, to add durability. So you know, when you think of a tooth, you know, you're born, you get a small cavity, you fill it. Maybe it gets a little bit bigger, you end up with a bigger cavity, and you know, at a certain point, the tooth is you run out of tooth, and at that point, it's hard to fill the tooth itself. So what we do is we essentially sort of create a smaller version of the tooth, and we put this sort of dome on top of it. Oftentimes, you know, that is something that happens later in life. So a lot of patients will need it much later in life, either because of recurrent decay, which is new decay under an old filling, or it's going to be because of fracture of the tooth from use that's been that the tooth essentially needs to be made durable again. Night guards.
Night guards are a useful tool in patients who exhibit some sort of clenching. There's many schools of thoughts of why clenching happens. It may be clenching, or it may be the sort of typical grinding where you actually where your teeth move against each other and you can hear, but it may just be a sort of flexing of the muscles to hold the teeth together. There's many schools of thoughts about the etiologies, and it's likely a complex issue. But in some patients, it is purely a sort of musculoskeletal situation where the muscles tend to sort of flex and tighten. The guard protects your teeth more than the muscles themselves, because that excessive pressure is not designed to be borne by the teeth, and it typically leads to a lot of wear and a lot of instances of cracking teeth. So the guard helps to spread the forces around and sort of provides a cushion for the teeth. In some patients, it's sufficient to sort of discourage the muscle the muscle flexing, and it may decrease a little bit of that sort of muscle tension and tension headache that comes with it, but not necessarily so all the time. It's mainly designed to protect the teeth from the consequences of the clenching.
Yeah. The teeth do wear differently between grinding and clenching. They're similar, but if you think of clenching, that's going to be if you're thinking these are top and bottom teeth coming together. If you were pushing them really hard, that's clenching. If you're grinding, you're actually sort of you're excessively grinding them or pushing them against each other. So the teeth wear on a grinder, you're going to see flatness on the top surfaces of the teeth. On a clencher, what we see is you're actually at the neck of the tooth, which if I was to point it out, in this would be the neck of the tooth here. You actually start to notice the cavitations. We call it abfraction along that area, along
like
the root.
ditches or divots, right?
Yeah. So if you notice that, that typically is a sign of clenching. Both are treated with night guards, but ultimately it's not solving the underlying issue, which is musculoskeletal, but really just protecting the damage that causes to the teeth.
So again, that might be something to discuss because you want to be able to diagnose that first, whether or not that is an issue.
Yeah.
And if it is, then the night guard is a great solution. But it's not necessarily a coverall for all wear and tear.
Yeah.
I found that using water flosser after string flossing and brushing finds hidden food particles. Absolutely. And again, it comes down to that sort of surface between the teeth increasing with time. If I'm pointing the cursor in these areas, so with aging, you get a lot more recession. So this triangular space becomes wider. When you have restorations like crowns and bridges, implants, again, that increases the space between the teeth. A floss will pass through these areas, but if this is too large, it will miss some. And so a combination such as, you know, the Proxa brushes or the soft picks or a water pick will then be a lot more thorough.
Yeah, one of the other things to also remember is these little, if you notice this triangle here, we call these embrasure spaces, and then this is the bone right here. So as you're starting to get chronic loss of bone, this bone level will decrease from here to down here, which is going to create a larger embrasure. That's going to have more food impaction from the side of the teeth, not just food impaction in between the teeth, but and that's where Proxa brushes and water picks are helpful for addressing that.
Okay. Becky says, how do you know if you need a root canal without any symptoms such as pain or very cold or hot food? So sometimes when you have a nerve that has died on the tooth without causing any issues, it may leave marks such as a fistula, so a a sinus tract or a little, what looks like a little sore on the gums against the tooth. Where it's draining from. So it has a small abscess in that area. If that's picked up, then that's indicative that the nerve has died. And another one is on the x-rays. So typically every few years or so, we'll do root x-rays, or your dentist may do root x-rays, or periapicals are called, to check on, again, the nerves and the bone levels. And occasionally they'll pick up pathology like this, where it's something that was entirely non-symptomatic shows up. And typically that necrosis on the nerve of the tooth causes a little bit of damage at the end of the root that shows visually on the x-rays, and that's how we are usually told. Does implant last forever? Do they have to be replaced? There's no sort of hard and fast rules with the longevity of implants, just like with any other mouth restoration. They're put under stress. If they're done well and if they're taken care of well, they can last, but it's not a guarantee that it lasts forever. And there's no sort of particular longevity that we expect from sort of manufacturers or mechanical standpoint.
Yeah, typically the goal would be for it to last a long time if it's properly maintained. We have patients that have had implants since the 90s and they're still in the mouth. The survival rate is really high. They do wear off, and but they can be functional for a long time. Oftentimes, when they are going to fail because of body's rejection or some other issue, it typically tends to happen earlier within the first couple of years of placement.
Is there a way to prevent or minimize bone loss around the teeth? So home care and care at the dentist in terms of removing plaque and catching pathologies that, disease around the roots and things like that, that will sort of weaken the teeth structurally, is important. Genetics has a big factor with that. And so the maintenance then becomes, proportional to the risk factors. And as you age, things like, the type of medications you're taking and the type of other sort of comorbidities or other systemic diseases that might contribute have a lot to do with it. Does a root canal have to be performed by a specialist? Not necessarily, but every dentist's sort of skill set is different. And in dentistry, you have the ability to take continuing education in whatever interests you the most. So some dentists are very proficient at doing root canals routinely, and others leave it to specialists. In general, the further back in the mouth you go, the more complex the root canals. So typically, molars or upper molars specifically will be something that, ideally a specialist should perform. A lot of them have the latest technology, microscopes and so on, that help do the job much more thoroughly.
Yeah, so it depends on where it is in your mouth and also the dentist, their experience. But typically, as a general rule of thumb, what Dr. Kraja said, molars to specialists, and then everything else can be done by a general. I have a bridge that's still fine after. Yeah, I had a patient the other day or a couple of months ago that had a crown that was done before he went to the Korean War, and it was still in his mouth. These things can last a long time. It's hard to put numbers on them because everyone's different. And generally, it's not the prosthetic material that fails, it's the underlying supporting tissue, be it an implant or the actual tooth that the crown's sitting on. We often replace crowns here because, as it ages, that something happens to the actual physical structure of the crown. That's more rare. It actually is something that happens to the underlying tooth. Yeah, because crowns are artificial, so they're not really going to be prone to it.
I'd like to follow up on something you said earlier about water picks. You said, if you use it properly. So can you maybe give us some do's and don'ts for proper use of a water pick?
Absolutely.
Yes, sure. Yeah, go ahead.
So what essentially the efficiency of the water pick has to do with the amount of time and pressure of the contact between the teeth. So typically we tell people to use to place that nozzle directly against the gum line of the tooth, sort of perpendicular to the tooth or parallel to the floor, and start with the power that's as high as you can tolerate it. It may be that when you buy a water pick or you start using it for the first time, you're at the minimum power, and as you build up sort of tolerance and confidence, you can turn that power up more. You want to spend about, if you can see the cursor, 1 to 2 seconds going gradually against this sort of curve of the gum line, and then about 2 seconds per interdental space. If you read the instructions of the manufacturer, they typically recommend 4 to 5 seconds per space between teeth. We find that sometimes it's a little bit aggressive. It feels like you're puncturing the tooth or you're puncturing the gums. It's not necessarily that, but if it feels a little uncomfortable, we split the difference where you're doing about 2 seconds in this interdental space here, then 1 to 2 seconds going gradually against the gum line, and then 2 seconds, and then you reposition. You may turn it off and reposition it to go towards the tongue side or the palate side on the upper, and then do the same thing so that the sort of amount of time between each sort of interdental space adds up to about 4 seconds or so.
Yeah, and especially for the elderly population, the water pick is really good for areas under the bridges. If you can't, a lot of times we find patients have a hard time cleaning. Bridge has the floating part, or the pontic as we call it. That's the part that's replacing the missing tooth. Cleaning under that is really important. That's typically where bridges fail, is the food getting impacted in there. Water pick is good for that. Just needs to sometimes have to go in and find the right angle to get the pressure water. Otherwise, it just bounces off the tooth. So that's important. And I think what I would recommend is maybe doing the floss after the water pick and seeing if you still get something on your floss. And then maybe that means that you need to adjust it a bit. But everyone's different.
Yeah. As a rule of thumb, typically there's two types of water picks. So the tabletop one, which has a cord attached to the handle, they have a bigger tank. At least you should aim for a full tank for your mouth, if not more. And then the portable ones where the handle with the tip is attached to a little tank that you can carry in the shower. They're great for traveling. They're great for, using it in the shower because of the water runoff. But the tank is much smaller. So you probably aim for 2 to 3 tanks to do a full mouth. So as a rule of thumb, in terms of whether or not you're using it for an adequate level of time, I usually use that as a guideline.
Yep. All right. It's 11:12.
Mm-hmm. How about dental implants? Should be done by specialists or not general dentists with enough experience? Again, this is an area, a bit of a gray area, because there are some general dentists with extensive experience that do great work. I would say in a situation where you're restoring multiple teeth at the same time, you want to see a specialist, or at least for the surgical portion of it.
These are our kids.
I was just going to say, I have a feeling that those are your 2 children.
Yes.
It's not indicative of the population, sir.
So obviously this has been a fabulous presentation. It's, we've gone almost 15 minutes over time, which means that people were very, very interested in this topic. So I definitely want to thank Dr. Kraja and Sidhu. I think that was the way to pronounce it. So for this marvelous presentation. And as I said, I did put the link to the radio show, the podcast that we did in the chat, so people can get more information about all of these topics. There's so much to talk about in terms of dental health and dental products. So I really want to thank you both for joining us today.
Thank you so much, Cheryl, and thank you everyone for attending and for the questions. We really enjoyed it.
Okay, well, just a reminder of next week, the topic is going to be what's new on the pike. And I guess the Columbia Pike Mart Partnership is going to talk about what's going on over in Columbia Pike in the Arlington area. And Andrew Schneider with the Columbia Pike Partnership will provide an update on this thriving corridor. So be sure and tune in on March 5th at 10 o'clock. So, and until then, have a good week.
Thank you.
Take care, everybody.
Okay.